Hello, and welcome to today's web chat about fibroids. Thank you for joining us. My name is Marissa Wetmore from the Michigan Medicine Department of Obstetrics and Gynecology, and I'll be your host for today's chat. 60 to 65% of women develop fibroids by age 50. Because so many women are affected by them, and because they are the leading cause of hysterectomies in the United States, fibroids are an important public health concern. Unfortunately, they're often not discussed, and that's why we're here today. I'll introduce our panelists in just a moment, but first, a few housekeeping items. If you can't stay for the whole chat or want to share a recording with a friend, a video of the chat in its entirety will be available on our Von Voigtlander Women's Hospital Facebook page, our Michigan Medicine Facebook page, our Michigan Medicine Twitter account, and posted to our Michigan Medicine YouTube channel shortly after. If you have any questions after the chat, please feel free to send a private message via Facebook or Twitter, or email us at ask-mishmed@med.umich.edu. All right, we're going to meet our panelists. Welcome, Dr. Erica Marsh.
Thank you, Marissa. So happy to be here. My name is Erica Marsh. I'm a reproductive endocrinologist in the OBGYN department at Michigan Medicine. I'm actually chief of that division, and I spend a lot of time seeing patients with fibroids and do quite a bit of fibroid research. So happy to be here with you and my esteemed co-panelist.
Thank you. And next we have Dr. Suzie As-Sanie.
Good morning, and thank you, Marissa, as well as Dr. Marsh and Dr. Townsel for including me on this really important panel. My name is Suzie As-Sanie, and I'm the co-chief of gynecology and the director of minimally invasive gynecologic surgery here at the University of Michigan. I see a lot of patients with uterine fibroids and talk to them about medical as well as surgical treatment options.
Thank you. And last but not least, we have Dr. Courtney Townsel.
Thank you, Marissa, and thank you again, Dr. Marsh and Dr. As-Sanie for having me here on the panel. I'm Courtney Townsel, one of the maternal fetal medicine specialists here at the University of Michigan in our OB/GYN department. I help care for women who have fibroids in pregnancy and help follow them through their pregnancy to get optimal outcomes.
Thank you. All right, we are going to jump right in. Dr. Marsh, why don't we start with the general overview of what fibroids are?
Happy to, Marissa. So fibroids are benign, meaning non-cancerous tumors or masses in the wall of the uterus. We know that these tumors are sensitive or grow in response to a couple of hormones that women produce, namely estrogen and progesterone. So while a woman is producing estrogen and progesterone, the fibroids tend to grow. That's not always the case, but they tend to grow during that window of time. And when women stop producing estrogen and progesterone, namely when they enter menopause, be that surgical menopause, natural menopause, or medically induced menopause, we see shrinkage of fibroids. I think it's important to note that most women, if you have a uterus, then you have a really good chance of having fibroids. But one of the good things about fibroids is that most people with fibroids actually don't have symptoms from them. So just because you have a fibroid, that doesn't mean you need to start taking medicine or that you need a surgical or radiological intervention. But if you do have symptoms from fibroids, then you tend to have multiple symptoms, and those symptoms can include things like heavy menstrual bleeding, pressure, bloating, and those are the types of things that can bring women to their providers, their healthcare providers' office. So highly prevalent. Again, as you pointed out, Marissa, 6 to 7 out of 10 women will have these tumors by the age of 50. And actually, if you're a woman of African descent, you have an even higher chance of having fibroids. We see closer to 8 to 9 out of 10 women of African descent have fibroid tumors by the age of 50.
Thank you very much for that overview, Dr. Marsh. And now we're going to delve a little bit deeper into some of the questions from our patients. So the first question, what are some of the symptoms of fibroids?
I will jump in and then ask Dr. As-Sanie and Dr. Townsel to also jump in, because I think there are a wide variety of symptoms, and certainly women in pregnancy can have a very kind of unique specific presentation. I think some of the things that we've highlighted, so heavy menstrual bleeding and pain can be probably the most common symptoms we have women present with. Some women who have fibroids can present with recurrent pregnancy loss, so repeated loss, typically in early pregnancy. Some women present with infertility, and we find out that they have fibroids. Some women present with frequent urination because fibroids are pressing on their bladder. Some patients present with constipation or lower back pain because they have a fibroid on the posterior, or what we call backside of their uterus, that's pressing on that area of the pelvis. So lots of different ways fibroids can present. I think every patient is unique. Every woman or female is unique, and their fibroids are unique as well. And so presentations can vary dramatically from person to person.
Yeah, that's fantastic, Erica. And I fully agree. I see that these symptoms are highly prevalent and common, but as you mentioned, not all women with fibroids have symptoms or have all of these symptoms. I think the other thing that's really important to always be thinking about, both as providers as well as patients, is that these symptoms, all of these symptoms that are very common in women with fibroids and can be directly attributed to fibroids in some patients, actually can be also multifactorial. And so there are a lot of other conditions that can cause the same exact symptoms. Both hormonal situations or hormonal changes can cause abnormal bleeding. Pelvic pain is a very common and multifactorial condition that can be caused by a lot of different underlying problems, and abnormal bleeding can not only be caused by fibroids, it can be caused by adenomyosis, they can be caused by endometrial polyps, as well as many other hormonal dysregulations like polycystic ovarian syndrome. So it's really important that we consider fibroids as one of the many conditions that can cause any of these symptoms, but having a very thorough evaluation to look at all of the potential causes. And for many women, it's more than one.
I definitely agree with you both. And I'll take a specific sort of chance to talk about pregnancy. And so we often see women in pregnancy who present with fibroids. As many as 2 to 10% of all pregnant women will have fibroids during their pregnancy. And many are asymptomatic during the pregnancy and do very well, have uneventful pregnancies. But I will say that the most common complication in pregnancy occur when women have large fibroids that can undergo what we call fibroid degeneration. And so outside of pregnancy, large fibroids take up a lot of our blood volume, and a lot of our blood goes to those fibroids outside of pregnancy. And once a woman becomes pregnant, that blood flow is diverted to the growing pregnancy. That sometimes causes some of the cells or parts of that fibroid to die or degenerate, which can cause significant pain for patients. It can be very scary for patients as well. So we'll often have to give patients medication to help them with that pain, even admit them to the hospital to watch them to make sure that they stay safe and that their pregnancy stays safe. So that's one of the more common things we see in pregnancy.
Thank you all. Our next question from our patients is, how much bleeding is too much?
So I'm going to jump in and say in pregnancy, any bleeding is too much. We always want to know if you're bleeding in pregnancy.
I think this is a really good question, something that Dr. Marsh and I have sort of talked about quite a bit on some recent panels and discussions. And generally, I would say to a patient is that if your bleeding is affecting your quality of life, then it's too much. So if you are feeling tired, if you are soaking through clothes, if your work and life and social activities are interrupted by the amount of bleeding that you're having, then it absolutely is too much and should be evaluated further.
I 100% agree with Dr. Townsel and Dr. As-Sanie, and would just want to add that sometimes we don't realize that sometimes we get so used to being tired during our periods, or so used to taking precautions when we're on our period, that extra set of clothes, the extra pads that we have or tampons that we have to take with us, that we don't realize that it is impacting our life, that it is forcing us to make decisions about going out socially or what we can do at work. And so I would really challenge the listeners and ask you to challenge your, take this to your loved ones, your friends, and say, it's not normal for you to be tired during your period. It's not normal for you to soak through multiple maxi pads and maxi tampons over the course of your menstrual cycle. It's not normal for you to bleed probably more than 5 to 6 days over the course of your period. So if your periods are lasting longer than that, if you're having to change regular or maxi pads every hour, every 30 minutes during the course of your period, even if you feel like that's normal for you, it's probably it may be too much bleeding and too heavy bleeding. And it doesn't mean that there's necessarily something wrong, but it's worth a conversation. It's worth reaching out to your healthcare provider and saying, I'm wondering if my bleeding, I've gotten used to this because this is how I bleed. This is how my mom's periods were. This is how my sister's periods were. But they may, I heard this talk and I'm wondering if they're a little actually too heavy. And just talk to your provider. They may want to check you to make sure you're not anemic, meaning have low red blood cell count. And if that's the case, that's another objective indication that you're probably bleeding too much or losing too much blood during your period. But I think it's important, everything that Dr. Townsel said, everything that Dr. As-Sanie said is spot on. But we as healthcare providers of women also know that women often minimize their symptoms because they are providers for family members, for parents, for children, for partners, and often, again, minimize their own health care. And so don't do that when it comes to heavy menstrual bleeding or abnormal uterine bleeding. If you have a question about it, it's okay to reach out to your provider and say, and ask the question and have the discussion.
Thank you. And can you tell us a little bit more about how fibroids are diagnosed?
I can jump in there. So fibroids are diagnosed most commonly by imaging, and the most common method is pelvic ultrasound. One of the things that we should remember, particularly patients and providers, is that transvaginal ultrasound, so ultrasound where the probe is placed in the vaginal canal, is the best way to view the uterus and the ovaries that are next to the uterus. And so that's probably the most common method. It's generally very sensitive, meaning that our ability to detect fibroids on ultrasound is quite good. But there are just certain situations in which we need to get a little bit more detailed imaging, and probably the next most detailed method is pelvic MRI. We don't need to do that for every patient, but there are certain situations in which we need to take that next step.
I would certainly agree with that, Suzie. In pregnancy, again, the majority of women are asymptomatic or don't know that they have fibroids until they have their first imaging during pregnancy. And so oftentimes in the first trimester, when you're coming to see how far along you are, we may diagnose one or more than one fibroids. We'll often tell you the size and recommend follow-up to just monitor how those fibroids are growing. The majority of fibroids in pregnancy grow in the first and second trimester and then sort of stop at that point. That's when we have the highest levels of hormones that Dr. Marsh talked about a little bit earlier. And so that's a sort of a critical point where we'll monitor those fibroids. But we often see them in pregnancy and we'll simply use ultrasound to do that.
Awesome, thank you. And how are fibroids treated?
I can certainly start on the medical side and transition to Dr. As-Sanie on the surgical side, and then to Dr. Townsel with how they're treated in the setting of pregnancy. But I want to start by saying that you don't have to treat fibroids at all if they are asymptomatic or found incidentally, on an exam, or if you're having an imaging for something else and they happen to find a fibroid, but it's not bothering you. So not just because you have a fibroid doesn't mean that you need treatment for it. If you have fibroids that are symptomatic, mean that are problematic, that are causing disruptions in your life, as Dr. As-Sanie mentioned earlier, those are the fibroids that we do want to address and treat. And I think of treatment falling into three main buckets. There's medical treatment. There's treatments that are what I call radiological and specifically interventional radiology, but some are just use are done by the radiologist. And then there's I think the largest bucket for fibroids, or a large bucket for fibroids, which is the surgical treatment options as well. I think depending on what symptoms you have and what your life goals are, that will drive your selection treatment. The treatment you select, I should say. We always try to start from a minimally invasive perspective. So some women may have slightly increased bleeding that can be controlled with over-the-counter NSAIDs, things like ibuprofen or Aleve. Sometimes women have or patients have bleeding that can be controlled by taking a birth control pill of some sort, or some progestin-only pill, or most often a combined oral contraceptive pill that has estrogen and progestin in it. We also have interventions or medical interventions that can stop the cessation or production of estrogen and progesterone. Things like leuprolide acetate, which is an injection that is given either monthly or every 3 months, that essentially puts patients in a temporary medically induced menopause that temporarily has the ovaries stop producing estrogen and progesterone. And in response to that, we can see fibroids shrink in size significantly, and we also can see bleeding stop completely. that medication is specifically approved to address anemia prior to surgical intervention for fibroids. But some providers do use it just to help address symptoms and in a shorter or medium term. There are also there's newer interventions that are coming out on the market now that are oral forms, oral medications that can temporarily stop the production of estrogen and progesterone that again are newer medications that are less known, but have been shown to be quite effective in the trials that were done before they were released that were an option. There are also medications that directly address clotting factors and bleeding factors. So tranexamic acid is an example of that type of medication. That's a medication that you take specifically during your period. There's a limit on the number of days that you can take it, and that's not a medication that you should take while you're on birth control pills, or if you're taking birth control pills or other forms of estrogen in particular. But if you're not taking estrogen containing medication, or if you can't take an estrogen containing medication, that can be an effective treatment for bleeding in particular. I think it's important to say that most of the medical treatments, or many of the medical treatments, are more helpful with the bleeding. There are some of the newer treatments that in some patients can be effective with bleeding and size of fibroids, but other than the leuprolide acetate, which is the injectable medicine, and some of the newer medications in that family, so that work along that same pathway, most of the medical interventions help with bleeding and cramping, and less with how should I say, less with the pressure symptoms or the bloating symptoms found with fibroids. And for those, and for sometimes the bleeding, if medical interventions aren't effective, I refer patients to a doctor like Dr. As-Sanie to learn more about the surgical intervention. So Dr. As-Sanie.
That's a great summary, Erica. And I love how you started out the conversation by saying how we treat really depends on the patient's symptoms and what her goals are. And so, as Dr. Marsh mentioned earlier, patients can have a variety of goals, and they can have a variety of symptoms. And so if their symptoms are primarily bleeding, medical therapy can be extremely helpful. But if patients have, what we call bulk symptoms related to the pressure and the size of the fibroids, those medical therapies don't tend to be as helpful, because most of them don't shrink or reduce the size of the fibroids, but really work to manage the bleeding. And so when I'm seeing patients, and if medical therapy is something that they've tried and hasn't worked and or isn't going to address their symptoms, I will often then talk to them about interventional treatments. And as Dr. Marsh mentioned, there are sort of two big categories of interventional treatments, those performed by our interventional radiology colleagues, primarily uterine artery embolization, which was approved over 10 years ago for the treatment of uterine fibroids and can be very helpful for many women. So uterine artery embolization, or sometimes referred to as uterine fibroid embolization, is a procedure in which interventional radiologists identify and basically block the main blood supply to the uterus, the uterine arteries. And then over the course of the next 6 to 8 months, fibroid volume shrinks and bleeding improves. In general, about 80% of patients report improvement in their symptoms following embolization. It is a very reasonable option for patients that allows them to keep their uterus. And so if they don't want a major surgical procedure that involves incisions, this is a good option. There are certainly some specific situations in which this is not an appropriate option depending on the size and the type and location of fibroids, but this certainly can be explored for some patients. Surgically, the two options that we can offer as gynecologists are either myomectomy or hysterectomy. So myomectomy is any surgical procedure in which you remove fibroids, but you preserve the uterus. And there are a lot of different approaches to myomectomy. Sometimes we can do it hysteroscopically, which is placing a small camera through the cervical opening and looking inside the uterus and shaving down fibroids that are in the lining of the uterus. Now, this is a great option that doesn't involve any incisions on the abdomen. It's an outpatient surgery. Patients come in and go home the same day and generally have good relief of their symptoms. However, it's very limited to patients who have fibroids that are in the lining of the uterus, and generally only those in which the majority of the fibroid is sitting in the lining of the uterus. If patients have fibroids in the lining and also have fibroids in the wall of the uterus, we often need to address both. And so it's certainly not a procedure for every patient, but one that is a good option for those with that particular type and location. If a fibroid's not in the lining, really the only way to remove it in the wall of the uterus is through an incision on the abdomen. We always try to do this through a minimally invasive approach, either laparoscopy or robotic surgery, but depending on the size and the number of fibroids, a minimally invasive approach is not always an option. Myomectomy is a really very good option for women who have only a few fibroids, for women who wish to preserve their uterus for future fertility. But it's really important to remember that it's not a cure. We can't always remove every fibroid, and fibroids do have a tendency to come back or grow new fibroids. And so it is sometimes a temporizing measure, but it is generally the most appropriate option for women who wish to become pregnant in the future, because it does preserve their uterus. And then finally, hysterectomy is the only cure for fibroids. It's the only procedure in which we remove the uterus, which is the source of the fibroids, as well as all the fibroids inside it. Now, obviously, this is a procedure in which you couldn't be able to carry pregnancy afterwards. And so it's really important that this is limited to, women who have no longer wish to become pregnant in the future, but it is the only cure. I think probably one of the most common misinformation about hysterectomy is that hysterectomy doesn't usually mean menopause. We almost always recommend preserving or keeping the ovaries at the time of hysterectomy. It is a major surgery. Most of the time we can offer it even to women with fibroids through a minimally invasive approach. So either a laparoscopic, robotic, or even potentially vaginal approach, depending on the size and number of fibroids. But there are, even with highly trained surgeons who do a lot of minimally invasive surgery, there are, situations in which the fibroids are just simply too big to remove through small incisions, and we need to make an open incision. So those are some of the things that we think about when we talk to patients about surgery options, but certainly not all of the details.
And I'll chime in a bit about pregnancy. So we certainly see two groups of patients. Some patients who have gotten pregnant with their fibroids in place. And for those patients, we typically don't treat the fibroids in pregnancy, but we will follow along in pregnancy. And when we follow along, what we do is we monitor the size of those fibroids and how well the baby is growing throughout the pregnancy. So that might mean ultrasounds every 4 to 6 weeks in your pregnancy to make sure the baby continues to grow well. And towards the end of pregnancy, we like to make sure we understand exactly where the fibroid is located and make sure it's not obstructing or in the way of the baby exiting the uterus through the cervix and getting to the birth canal. And so that's information that we'll also provide to your healthcare providers. In the case of patients, and oftentimes I just want to make it very clear, women with fibroids, we strongly recommend and advocate for a vaginal delivery. That is our number one goal for patients, and we talk about that extensively during the pregnancy. There are situations where women have fibroids that obstruct the baby getting out of the birth canal, and we can talk about that individually with each patient. Now, we often see patients who have seen someone like Dr. As-Sanie and have had their fibroids removed, whether that's from a minimally invasive procedure where they have had them removed with that small scope through the vagina from inside the uterus. And sometimes that's through the large incisions or the incisions on the abdomen where they're removed and an incision is made into the uterus. And it's important for your OBGYN to understand which type of procedure you've had because that can impact a future pregnancy. So if the uterus is, if there's a cut on the uterus and the endometrial canal or the canal where the baby is held has been entered, then we typically think those patients need to have a C-section in a future pregnancy. If you have a minimally invasive surgery done laparoscopically, as Dr. As-Sanie mentioned, then we usually continue to recommend a vaginal delivery and advocate for that because outcomes are very good for patients who've had minimally invasive procedures. Again, the recommendation is to make sure you have a good discussion with your provider and that they review your operative report so that we can sort of counsel each patient appropriately.
Thank you all. Do fibroids ever just go away?
That's a really interesting question. And I would say up until a few years ago, we would say no, you know, that doesn't happen. That can't happen. They once you have them, they just grow. But a study, there's two scenarios really where we have seen them shrink and in some cases go away completely. The first scenario, I guess maybe not surprisingly, is in the setting of pregnancy and after delivery. During pregnancy regress and in some cases completely get resorbed as the uterus shrinks back down to its normal size after delivery. Actually what is happening to the fibroid is not perfectly clear because fibroids consist of cells and they consist of what we call extracellular matrix or fibrous tissue, which is where they get their more common name fibroids from. It's somehow, there's some remodeling of the uterus that can happen after delivery that allows for the fibroids to become more part of the fabric of the uterine wall. Even outside of being postpartum or after delivery, we do see fibroids shrink spontaneously. Again, as I mentioned earlier, we used to think, I'd say 10 years ago in the field and before, we used to think that fibroids only went in one direction, and that's that they just grew and kept growing. We knew that different fibroids and different people grew at different rates, but there was a really well-designed study done down at the National Institute of Environmental Health Sciences that followed women who had fibroids and had them have an MRI, the imaging that Dr. As-Sanie referred to earlier, every 6 months or so, and showed that in those women, even in the same woman's uterus, some fibroids grow, some fibroids don't change size at all, and some fibroids shrink. It's hard to predict which fibroids are going to grow, which fibroids are going to shrink, and which fibroids are just going to sit there and not change over time. But we do know that each fibroid is unique. It's not even that each patient is unique, but more than that, each fibroid is unique. And sometimes fibroids can shrink and even go away. That should not be the backup plan, though. That is not the rule. That's more the exception to the rule. So I think if the patient is having moderate to severe symptoms, the plan should not be, well, maybe my fibroids or maybe her fibroids will just go away, because that is not typically what happens. But it is important to acknowledge that occasionally, in some cases, that does happen.
Dr. Marsh, that's super interesting data. Do you know if it depends on how big the fibroid is? I mean, I would imagine if a patient becomes symptomatic when her fibroid is 6 to 10 centimeters, I would assume that we could confidently say this fibroid's not going to shrink enough before menopause that it's going to go away. Is that more relevant to patients that have much smaller fibroids, like 1 to 2 centimeter fibroids? Do we know?
Dr. Sanie, I would have to go back and look at the primary paper. It's some of Donna Baird's research, and I know the net growth was found to be about 9%, or the net change in size per unit time was about 9%. But I'm trying to remember if they looked at by size of fibroid. And my thinking is they did, because the change in size was a percentage. But I would have to go back and look at that. That's an interesting question. And I would suspect, I would agree with you. I don't think that while a smaller fibroid would have a better chance of disappearing completely, I don't think you're going to see a 10 centimeter fibroid disappear completely. I think the chances of that are close to zero.
And I would agree with Dr. Marsh. We know that 90% of women who are found to have a fibroid in the first trimester will have regression in size and volume of their fibroids 3 to 6 months postpartum. And so if they can just kind of hang on and see how their symptoms are postpartum for a reevaluation, that would be a good idea.
And that's a great point, Dr. Townsel, because I certainly see patients after pregnancy, and we'll always let them know, even if you do need a myomectomy, we want to wait until they're at least 6 to 9 months out from their pregnancy to give it a chance to shrink and stabilize before considering surgery.
Thank you. What are the chances that fibroids return after treatment?
I can at least jump in there and talk a little bit about myomectomy, because, we know that with medical treatment, fibroids aren't generally going away. We're managing the bleeding related to the fibroids, but not necessarily have the goal of removing or eliminating fibroids. But with myomectomy, the surgical procedure that we talked about, where we remove the fibroid and preserve the uterus, it really depends. The data is not entirely clear, but we do know that there is a relatively high chance that if you have a myomectomy, you will have recurrent fibroids at some point after the surgery. So in one group of references, anywhere between 5 to 10 years after myomectomy, anywhere between 1/4 to 2/3 of women will have fibroids that we can detect on ultrasound. But considering, exactly what Dr. Marsh said, not every patient that has fibroids has symptoms from their fibroids. And so considering the background prevalence of up to 60 to 70% of women having fibroids, it doesn't necessarily mean that if you have recurrent fibroids, you will have symptoms. In another study, I think that's probably a little bit more relevant, is that if you have a myomectomy, anywhere between 10 to 25% of women will have enough symptoms that they end up undergoing a second major surgery in 1 to 10 years. We don't know exactly what are the predictive factors, but probably one of the most important predictive factors is how many fibroids do you have to start with? How many were removed? Because we do think that biologically, the patients that have maybe just 1 or 2 fibroids are probably very different biologically from the patients that start out with 10, 15, 20 fibroids. And so those patients that have multiple fibroids are probably at a higher risk of recurrence than those that have just 1 or 2 fibroids that are removed entirely.
Thank you, Dr. As-Sanie. Another question from our patients, are fibroids cancerous?
I'll jump in. I'm sorry. So many jumping in so much. This is actually a very, very common question, a really important question, and a question where we actually think the data, we're learning more and the data is changing a little bit over time. Fibroids themselves are benign. So when we talk about leiomyoma, those are benign smooth muscle tumors that arise from the uterus. The problem is that we don't have a very accurate way of distinguishing them from another type of tumor of the uterus called a Lyomyosarcoma, which is a cancerous tumor arising from smooth muscle of the uterus. So we don't actually believe in, Dr. Marsh and Townsel should correct me if I'm wrong, but as far as I'm aware, we don't have any evidence to suggest that a benign fibroid transforms into a malignant one. But what we don't know is, what we don't have a good ability to distinguish is those cancerous tumors, the leiomyosarcomas. We don't have a very accurate way on imaging, on blood tests to distinguish them from benign fibroids. So we estimate that leiomyosarcomas, they're incredibly rare type of cancer of the uterus. They're less than 1% of all types of cancers of the uterus, but they are highly malignant and have a very poor prognosis. In women that have uterine tumors, we don't know exactly how common leiomyosarcomas are, but they're anywhere between 1 in 500 to 1 in 7,000. And in part, it depends on what study you look at. In part, it depends on, are patients symptomatic? Are we looking at patients across the board that are or not having surgery? Or are we looking at just patients that are symptomatic enough to need surgery? So we think in general that it's rare. We know that it's more common the older a patient is. And so, you know, in a postmenopausal woman, it's going to be more common than in a woman her 20s or 30s. But in general, we think it's a very rare type of tumor in the uterus.
I think Dr. As-Sanie gave a fabulous response. I just want to kind of reiterate that fibroids by definition, or leiomyomas by definition, are benign. And the challenge is knowing for sure whether a patient has a leiomyoma, or, you know, what we commonly call fibroid, versus a leiomyosarcoma, which is something very different from a fibroid. I agree with Dr. As-Sanie. I haven't seen any data to suggest that fibroids turn into cancerous tumors or transform into cancerous tumors. But the challenge, as Dr. As-Sanie said, is that we don't have a great system to detect or determine whether something is a fibroid for sure versus a leiomyosarcoma. I think age is the best marker we have to reassure patients. To some extent, rate of growth is reassuring. Certainly, if we see something that's fast growing in a postmenopausal woman, we are highly alarmed and concerned. In a premenopausal woman, we know that fibroids can grow quickly in some women, so that's not necessarily a red flag of concern. I think in general, we certainly, radiology is not perfect, but We always counsel patients that until we have pathologic diagnosis, we can't say 100% that something is what we think it is. But in the vast majority of cases, meaning more than 99% of cases, when we think it's a fibroid, it's a fibroid. So I think hopefully patients are reassured by that. And I know there's a lot of work in the field to address that and also to minimize risk around if something doesn't end up being what we think it is, how can we minimize surgical risk around it? So I think that's all I would add.
Thank you both. And how do fibroids affect fertility?
I think I can take this one. I first want to start by saying that there are plenty of patients that get pregnant, of people that get pregnant who have fibroids, okay? So having a fibroid or fibroids does not automatically mean that you are going to have difficulty getting pregnant. I think having fibroids can impact pregnancy, and particularly fibroids that are either in the cavity, in the inner portion of the womb or the inner portion of the uterus where a pregnancy would implant, but also fibroids that are near the entrance of the cavity to the fallopian tube and can grow and compress or block the entrance to the fallopian tube in the uterus. They can prevent the sperm and the egg from ever meeting because of compression of that opening, those openings to the fallopian tube, which we call the ostia. So fibroids typically in the wall of the uterus are less worrisome. However, we do have data now that shows an association between cavity length and pregnancy rate in the setting of a procedure I do called in vitro fertilization, or IVF. And we know that a larger cavity, and that's typically one that may be distorted by having fibroids in the wall of the uterus, or be enlarged for other reasons. There's a lower pregnancy rate associated with both a very small uterine cavity and a very large uterine cavity. And on the very large side of things, fibroids are a common cause of an enlarged cavity. So again, just because you have fibroids does not mean that you are going to have infertility. Just because you have infertility and have fibroids, it doesn't mean that fibroids are the cause of your infertility. I think it's important to have an evaluation to see where the fibroids are, if you're having any other symptoms from them, and to come up with a plan with your infertility specialist, as well as with the entire healthcare team, which can include doctors like Dr. Townsel and Dr. As-Sanie, in terms of coming up with the right plan for the right patient.
I would just add that I often see patients who do become pregnant and have fibroids, and they're, a common question may be, well, am I at risk for a miscarriage? And the older data would say that, yes, the miscarriage rates are higher in patients with fibroids, but newer literature that takes into account other patient factors, age, et cetera, have shown that actually there's no increased risk of a miscarriage if a patient has fibroids. So I'd like to encourage patients who become pregnant with fibroids that they typically have an uneventful pregnancy and do well.
And the only caveat to that is that doesn't include patients with recurrent pregnancy loss. Okay, so if you've had multiple losses and have fibroids, the fibroids can be contributory, but a single miscarriage, the data, Kathy Hartman study, that data are very clearly show that what we thought was the case, just the presence of fibroids in general are not associated with a single loss.
Well, thank you all. We are nearing the end of our chat together today. So I just want to check in and see if anybody has anything else they want to comment on, share with our patients about fibroids before we wrap it up.
I would just like to say thank you for this really, really informative discussion. And I just would, reinforce to patients that you should always not fear discussing this, with your provider. And if you don't feel like you're getting the right answers, then, keep looking and, get a second opinion. You are your best advocate, your family is your best advocate, and there are a lot of treatment options, and some of which are just to keep watching. So, we're certainly here for you at the University of Michigan and available if needed.
I would agree with that, Dr. As-Sanie. For patients who are pregnant with fibroids, I would encourage you to know that most pregnancies are uneventful and do just fine. We certainly would recommend that you talk to your provider about specific concerns or complications that may arise, such as the degenerating fibroid for patients with larger fibroids. And sometimes those fibroids that enter the cavity may, not allow the baby to turn in the right way. So just monitoring the growth of the pregnancy and just following you along is the most important thing, that patients do really well in pregnancy.
And I would encourage anyone listening to reset the bar for your own health. And if you have been dealing with some of the symptoms that you've heard us talk about today, do not just settle for, well, it's okay, it's just what I have to deal with, monthly. Oh, everybody in my family has this. Oh, I don't have time to take care of myself. Make the time. You are worth it. You deserve it. And you need to focus on your health. Fibroids are common. There's not, given their prevalence, there are not as many medical options as you would think that there would be, but there are some, and there's certainly some interventional options that we have. And all of you are different. All of you have fibroids that are different, and all of you will need different approaches and treatments to match your goals and life plans. Having fibroids, we think of fibroids as a bread and butter gynecological condition, but you are not bread and butter. You are all unique. So please reach out to a trusted provider. Let them know what's going on and what your concerns are. Ask questions and get the treatment that allows you to be your best self and to live your best life. You should not feel like you have to sequester in your home for half a month because of pain or heavy menstrual periods or fear of soiling your clothes out in public. We may not have perfect options, but we have a lot of good options, and we can typically come up with a plan that helps you get to a place where, again, you can be your best self and you can live your best life, which is what we want for you. So thank you, Marissa. Thank you, Dr. Townsel and Dr. As-Sanie. It's always a privilege. And ask questions, patients, get empowered, get the information you need to know. And if you need it, get treated.
Dr. Marsh, Dr. As-Sanie, Dr. Townsel, thank you for sharing your expertise and your time with us today. And thank you to our audience for spending part of your morning with us. You can learn more about our services at www.umwomenshealth.org. We hope today's chat has been helpful and you have a wonderful afternoon.
Thank you.